Good morning, everyone. I want to thank Christy and John for allowing me to speak and awarding me with the prestigious position of the Starbucks Memorial First Lecture.
With a few comments, and Goldberg.
Especially after last night, which was a lot of fun for all of us. So the title of my talk was Education, 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 differentiating between lifestyle-induced high cholesterol and autosomal dominant genetic lipid disorders. I think it's actually much simpler than that, and just identifying people who have inherited lipid disorders versus those maybe who have secondary causes of elevated cholesterol. You know, I always think about teaching and medicine, and I think everyone in this room is an educator. I had an interesting experience a year ago. I have two young kids. My daughter at the time was in first grade, and they were having one of those sessions in school where the teacher asked everyone what their parents did. And everyone apparently went around the room, and when it came time for my daughter, she said, "My daddy's a teacher." And the teacher actually called me up and she said, "Aren't you a physician?" And I said, "Yes, but that's what they think about how I spend my day." And I realized that's how I feel about what I do. And so it really made me feel good to be able to give this discussion today, and these are my disclosures. But before I started, I also, as the New Yorker here, wanted to welcome everyone to New York City. I wish I could have given this information to you yesterday, but for those of you who are staying any later, I wanted to make some of my own recommendations. So if you decide to go to a Broadway show, Beautiful, which is the story of Carole King and her life actually up until when she released the album Tapestry, is amazing, and it's worth going to. And if you like Italian food, our favorite restaurant is a place called Spigolo, which is on the Upper East Side of New York. It's small by any other standards. I think there are 3 seats at the bar, but it's absolutely wonderful, and it's one of those secrets New Yorkers don't tell people about. And then finally, if you have any time and you want to go to a museum, the Whitney has some amazing exhibits. There's a Hopper exhibit there right now, which is beautiful. And also, if you've ever seen any of the art of Jeff Koons, does some very interesting art. We took our kids there the other day. He had some interesting exhibits shown. One was this basketball suspended in water, which my 11-year-old was thrilled with. And then right next to it was this mound of clay, which he said was Play-Doh. And of course, all I could think of was the lipoprotein particle and the plaque. So that's the way I remember things. I said, gee, that looks familiar. Anyway, so I also wanted to tell you a little bit about the history of my institution, which is NYU in Bellevue. Bellevue Hospital, for those of you who don't know, is the large city hospital here in New York. It's kind of the centerpiece of our 11 hospital system here in New York City and all of the boroughs. This was Bellevue Hospital when it was first built in the 1700s. It was then and is still now a hospital for those who have nowhere else to go. And you can see it was right on the banks of the East River, quite an idyllic setting at the time. You get pictures of sheep grazing in front of the hospital and stuff like that. In the 1800s, they rebuilt Bellevue. This is a postcard a patient gave me. They called it New Bellevue at the time, and it was quite the impressive facility, still with a park out front, and the boats would actually cruise up and down the East Rivers collecting patients and then dropping them at the front door, so to speak, on that park there. The job of the house officer was to unload the patients from the boat and bring them inside. Their job really hasn't changed that much since then. Fast forward to the early 1970s, this lovely building was essentially deposited right on the imprint of the old building. You can see it literally dropped right around the sides. You can no longer walk to the river. We now have a highway that rings New York City, thanks to Robert Moses. And so this was the building I had the pleasure of training in. And then more recently, we have a beautiful new building, which is where our lipid clinic is now, and it sits right on the front side of the building on First Avenue. You can see the fronting of the old building underneath that. And, you know, when I think about this, I also think about the way progress has affected the field of lipidology. And in the 1980s, when I was training, these were the medications that we had available to us to treat patients with inherited lipid disorders, immediate-release niacin, gemfibrozil, and bile acid sequestrants. So fast forward to 2014 at Bellevue, I have niacin, fenofibrate, again, generic bile acid sequestrants. We can use simvastatin, and if a patient fails, we can use rosuvastatin. And only recently were we able to convince our P&T committee to give us ezetimibe, and that's only for FH patients. And I'm telling this story because I'm going to show you how I believe this actually affects education. Like many people here, I had mentors and people who impacted my life during my training. When I was an intern at Bellevue, I had this resident who I was assigned to who kept poking around and looking at everyone's cholesterol. That was Terry Jacobson, who's now the president of the National Lipid Association. And even prior to my time at Bellevue in high school, I met this wonderful guy who used to tie my sneakers in a knot and throw me backwards down a hill. I then met him again at Bellevue, and that was Dr. Seth Baum. And we've been friends ever since and interested in the field of lipidology. I'm lucky enough to train at the NYU Center for Cardiovascular Disease Prevention, where Ed Fisher and Ira Goldberg are now also here. So we've got a wonderful center. So my goals here were to understand the gaps in diagnosis, understand the role that educational programs and agenda can play in improving identification and diagnosis, and then review what these educational and awareness programs might be. So we've seen this slide over and over again, and again, this idea that about 10% of patients in the United States are being diagnosed with FH. That seems like a small number, but it actually to us seemed like it was even larger than it should be based on my knowledge. More recently, we've had data that I think that more accurately approximates our diagnosis rates here in the United States, and unfortunately it looks like it's as low as 1%. Now, this is information that Josh has been trying to get me to write into a real article, and we just haven't gotten around to it, but we presented it as an abstract a couple of years ago. And we actually did a chart review. We looked at about 170,000 charts through an electronic medical record database analysis. We used the Dutch Clinic Lipid Network scoring system. It's a little easier to put into an EMR-based evaluation. And what we looked at were patients who might meet criteria for possible, probable, and definite FH. And we saw anywhere between about 1 in 294 and 1 in 310, depending on whether you accrued probable and definites. But what was most interesting to us is we went back and we did a hand chart review of every single chart, looking for anything that might possibly make us believe that the practitioner thought the patient had an inherited lipid disorder. And unfortunately, it was around 0.5%. So again, this was in an academic medical center. These are people who should know and understand FH, and they obviously don't. Now, a lot of physician education comes from patients, and I know we're going to talk about that, but I think patient awareness circles back on physician education, and this is some information that was published a couple of years ago in the Journal of Cardiovascular Nursing, and it was kind of highlighted again in the NLA statement that was published in 2011, that in one examination of 74 patients with FH who were given a questionnaire, most patients knew about cholesterol and prevention and drugs, but had very little knowledge about the risk of genetic transmission. And obviously, this was a while ago now, and I think that things like the FH Foundation have changed that. We've also seen this slide before, but I'm going to show it to you in a different context, which is the idea of this overlap between phenotype and genotype. And I think one of the things that's important about this is for everyone here in the room, we understand what this slide means. But for most general practitioners and cardiologists who aren't interested in the lipid world, understanding the idea of phenotype and genotype overlap is more complex. And this is one of the things I think that sometimes confuses people in general practice, and they don't quite understand how to take this information and translate it into identifying risk and treatment paradigms. And it gets even more complex when we look at the variability in the expression of a variety of different mutations that cause homozygous FH. Again, we can have a varied presentation in phenotype based on the type of mutation. And so, again, people in their mind have an idea of what the diagnosis of FH is or what homozygous FH is, but when we start to show them information like this and they say, well, it can be much lower or it could be higher with a different mutation, I think, again, this is where education starts to play an important role. So in 2011, here in the US, the National Lipid Association published a wonderful comprehensive document on the approach to the patient with FH. In 2013, as we all know, AHA and ACC published their guidelines, and right smack in the middle there was LDL greater than 190. I wish it had said FH, And if you read down into the document, obviously it says that, but the importance of identifying patients with inherited lifelong lipid disorders was brought to the forefront. More recently, the National Lipid Association has released recommendations for the management of dyslipidemia. And then actually the first part of that document, again, greater than 190, is all that's listed. If you dive down to Table 9, you see greater than 190 and severe hypercholesterol phenotype, which includes FH. So again, we've certainly seen movement within guidelines and recommendations to identify patients here in the U.S. who have FH and moving away from our older ATP3 recommendations, which did not highlight the importance of risk in these patients, lifetime risk in these patients, and understanding why not to use risk calculators. But when it comes to education, I think it's important to note that there are a variety of different places that we can look to for guidance. And in that NLA document in 2011, there was a wonderful section on future issues, public policy, and awareness. And this is a summary of those recommendations, and I've expanded for you the responsibility for education. Health systems, hospital, pharmacy, benefit management organizations, and insurance companies should contribute to patient and provider education. I also believe they need to be educated, all right, for providers, for pharmacies, for a variety of different institutions to contribute to education. They actually have to be aware of what the condition is and how to manage it. Governmental agencies and other policymakers at local, state, national, and international levels should be engaged in efforts to screen and treat FH. So I broke it down into 4 groups: patients, healthcare practitioners, which is really what I'm here to talk to you about, institutions and public health. But the reason I've listed patients, institutions, and public health is all of those also serve to educate healthcare practitioners. So you can't look at any single one of these out of context of the others. I thought about this over and over again, and it's impossible to do it without looking at them all together. So when it comes to patients, obviously, things like the FH Foundation, the foundation of the NLA, social media, Facebook, Twitter, other internet-based programs, discussion forums and chat rooms, things like the FH Cascade Registry. This is a wonderful infographic on the use of social media and who people trust the most in social media. And over there in the top left at 60, that's doctors. All right? So people really do look to doctors in the context of social media to understand who they can trust. And here at the FH Foundation, we had a wonderful Twitter chat on FH Awareness Day, and you heard about how many people were impacted by that. Healthcare providers. So what do we need to do? I believe the real way we can make an impact is early on in training. Medical school, nursing, pharmacy, physician's assistant curricula. This is where we really need to get out and change the way people are taught at an early stage in their training. Training programs. We have one in lipidology targeting fellows or medical health house staff. Our house staff rotate through our lipid clinic. It's really the only formal lipid training that they get, and for most of them it's an eye-opening experience when they come through our clinic. Postgraduate CME programs focused on FH awareness and treatment, and then hospital, lab-based, and practice-based screening programs all can play a role in increasing awareness and obviously the registry. So when it comes to awareness and education, we've talked a little bit about the field of lipidology and it being under-recognized. This is just an example of what happens if you go to the Medscape website and you try to sign up as a lipidologist. So they ask you to create a new account. And then they ask you your profession and your degree. And then finally, they ask you for your primary area of practice. And for me, all I could write is other clinical and other clinical. And so I actually wrote an editorial about this. Lipidology is not otherology, because I think that until people recognize who and what we are, they will not understand the conditions that we take care of, or they will not have an awareness of the people who have these abnormalities. So I do think this is important, and so I encourage people, every time you see a drop-down menu like this, email the webmaster and say, you haven't included my specialty. So how do physicians learn? I'm very interested in this. There was a great article that was in Time magazine a while back. It was based on some stuff being done up at Harvard on education. And what they focus is on the traditional way that physicians learn in medical school and training, which is what's called binge and purge. Basically, it's you know, GI pathophysiology, shove as much in as you can, and then when it's time for cardiology, get rid of it and move on to the next. And unfortunately, I see this in our lipid clinic. I mean, I know these are smart house staff. They've gone through wonderful internal medicine and medical school training programs. And then when they get to lipid clinic and I ask them how a statin works, I get a blank stare. And I know they've learned it, but they've forgotten it. And that's because basic science isn't reinforced once they get into clinical training. At NYU, we have a new curriculum now. It's called the spiral curriculum. And what we do is we constantly reinforce clinical training early on and basic science training later on, so that this is constantly worked back and forth and they understand this idea of integrated curriculum, and also something that we call spaced repetition, that you have to see things over and over and over again. How many people remember the art of Jeff Koons? Right? That's spaced repetition. I've just reminded you about it again. Need to integrate this beyond training to graduate medical education and postgraduate education. Institutions play a role. Hospitals, healthcare systems, payers, lab testing providers, pharmacies, and prescription benefit providers. This is a poster we presented a while back just on our experience lobbying our own P&T group to actually approve ezetimibe for patients with FH. And we had to sit down with them and we had to explain to them why this was reasonable and considered state of the art. Once we did, what was great is now people refer patients to us because they have identified them as FH because they want to use ezetimibe. So again, it was a backhanded way on increasing awareness within our own system and also getting a drug approved. Public health initiatives, things like FH Awareness Day. In the state of Michigan, they've done a very good job of starting to promote FH Awareness Day and encourage cholesterol screening. And then you'll hear more about this, but at our own CDC genomics implementation. I was lucky enough to be part of this about 2 years ago now, and looking at the role of tier 1 applications, particularly when it comes to genetic testing in the field of FH. So in summary, there remains a gap in education between differentiation between high cholesterol and autosomal dominant inherited cholesterol disorders. There's an overlap between phenotype and genotype that I think creates some confusion regarding identification of these patients. Underdiagnosis continues in the US, and there are multiple pathways for improving provider education, including those focused on patients, providers themselves, institution, and general public awareness. So thank you very much.